All right, hello everyone. Welcome. We'll give everyone just a couple seconds to join in. See more people joining. Welcome, welcome. All right, so we got a lot of good content today, so we're going to go ahead and get started. So today you're going to be hearing from the Centauri team from Pledge to Practice. Before I turn it over to them, I'm going to go through just a few housekeeping items. So you will notice for the duration of the webinar that your camera and your mics are going to be muted and off. This is just for your privacy. If you do have any questions at all, please feel free to put those in the chat, which is going to be found at the bottom of your screen, or I'm sorry, in the Q&A box found at the bottom of your screen. The team is going to go through those questions at the end of the webinar, and if there's any that they're unable to get to, not to worry, they'll follow up with you directly afterwards. In addition, Rise will be sending out an email tomorrow following the webinar with access to today's slides as well as a recording to today's session. So without further ado, I'm going to go ahead and turn it over to Dawn to get it started.
Good afternoon, everyone. Thank you so much for joining us today. I'm Dawn Carter, of course, from Centauri Health Solutions. I'm the Senior Director of Healthcare Policy and Regulatory Affairs, and I am joined by Dr. Holly Miller, who is our Chief Medical Officer and Strategic Advisor. And we're so pleased to be here with you today in hopes that you come away from this webinar with a simple, practical way to understand two core actions we all rely on: finding the right information we need and sending the information someone else needs, and how getting those right can improve care and reduce administrative burden. So, as an overview of our roadmap for today, our path today is talking about adoption drivers for interoperability, query pull versus push interoperability. Then we'll look at TEFCA and the network of networks. We'll segue into the importance of direct and 360X. Then we'll move into SDOH loop closure and why it matters in terms of costs and outcomes. And throughout, we'll keep returning to the same practical question: does this interoperability approach reduce burden and improve decisions in the real workflow of value-based care programs that address SDOH? And so first, we move into now on the next slide, our first polling question. And we've got three options here for you to choose from, three questions. So before Dr. Miller gets into the mechanics of query versus push and the frameworks that enable them, I want to anchor us into why this matters right now, because interoperability has shifted from a future goal to a present operational requirement for care, payment, and performance. So the first thing that we want to be thinking about is that advancements in interoperability are coming hard and fast. Interoperability is no longer just about getting access to data. It's about getting the right data at the right time into the right workflow. And the pace of that matters because organizations that are treating interoperability as just some one-time IT project tend to fall behind. The winners treat it as a capability, something that you continuously mature: the data, the workflows, the governance, and the adoption. And as a result, interoperability is the cornerstone of value-based care. Now, value-based care depends on visibility across settings, which depends upon continuity and knowing what happened outside your four walls, whether a referral was completed, whether a care gap was closed, or whether a member actually received the services that were recommended. And now I'm referring to that first question, which is, how many of you have seen a referral made and then can't confirm what happened next? And out of our 27 responses, the overwhelming majority have said, yes, we have seen that happen. So hopefully today you will come away with an understanding of the work that's being done to try to address that. So as far as the administrative burden, we're going to talk about that as well. So as a result here, this is exactly why we're going to spend some time on push workflows like Direct and 360X, because value-based care isn't just about finding data, it's ensuring that actions happen and are confirmed. Also, interoperability and its relevance to today is support of what we know as the quintuple aim. And this has evolved from the triple aim. And the quintuple aim is a practical North Star for healthcare transformation. It involves improving outcomes, improving patient experience, lowering the total cost of care, reducing clinician burden, and advancing health equity by making the right information and services flow reliably across the care continuum. Now, in the context of this presentation, interoperability is the how. It enables coordinated care and less friction and burden. And so that speaks to this question: for how many of you does this entire referral process take more than an hour? And so it's a split. For about half, 48%, it's yes, it does take more than an hour. And for about half, it's no, it doesn't. So this also, like I said, enables coordinated care, less friction, supports value-based care goals, and it makes the SDOH referral loop closure measurable so that equity efforts translate into real-world results. Also, we care about this and its relevance because it enables better outcomes and safer care. When clinicians can see a more complete picture, problem lists, meds, recent visits, consult results, care is safer and more coordinated. Also, we know it lowers cost, reducing duplications such as repeated labs, repeat imaging, avoidable admissions. This requires data to move with the patient and not stay trapped in a system in silos. Also, as we've mentioned, it lowers the provider and administrative burden. This is often underestimated. If incoming information is structured and usable, you reduce manual transcription, fax chasing, phone tag, and the administrative scavenger hunt. And for this third polling question, again, we're about split half and half. For how many is interoperable data received, patient member information readily available, reliable, and usable? About half said that it is, and about half said that it is not. And then last but not least, health equity. Equity isn't a separate track. It's what happens when the system can actually see unmet needs and coordinate supports. That's where the SDOH referral loop closure becomes a practical equity lever, and I'll discuss this more in detail later in the presentation. So the aim here isn't more data. The aim is actionable, timely data that changes decisions and closes gaps. And now I'll turn it over to Dr. Miller, who will shift us from the why now to the what works, the adoption factors that turn interoperability from connectivity into measurable workflow and outcomes. Dr. Miller.
Thank you, Dawn, and good afternoon, everyone. I'll speak to you of all of the aspects that you see on the slide leading to interoperability adoption as I go throughout my section of this talk. First and foremost, the data received must be available, reliable, and usable. What ensures this are the frameworks specifying and governing the networks that are moving the data. Next, the workflow must be easy and optimal for each end user, regardless of their role within the organization. The health information technology, EHRs, for example, must have optimally designed user interfaces and features. Burden reduction occurs when the data from the sending system has been documented as coded data, meaning that the data is both machine and human readable, such that the recipient system can ingest this data, decreasing documentation burden. This is managed by EHR certification requirements to use the same or more advanced US core data for interoperability, known as USCDI. Finally, interoperability adoption must benefit patient care, including both clinical care, health plan member care, and other care. Let's start with an overview of frameworks and networks. In this diagram, the blue rectangle above is the framework for these networks. The orange circles are the edge systems with the examples listed, and these red lines are the networks. Frameworks govern and define requirements for networks. Networks exchange data from edge system to edge system. Frameworks for networks have several roles. Governance, defining policies, common agreement, terms of participation. They also participate or govern moderating dispute resolutions. There are technical, privacy, security, and legal requirements defined for participation, including creating technical implementation guides, standard operating procedures, and testing and recognition of the networks within the framework, and defining the exchange purposes and response requirements. Networks operating under all aspects of their given framework, deliver data from one edge system to another. I wanted to talk about the benefits of interoperability. We've touched on this, but it's important to understand. Discrete or coded data is both human and machine readable. Therefore, this data can be ingested from one system to the other, which can greatly decrease transcription burden and help prevent transcription errors that might lead to adverse events. Many EHR systems have the ability, once the data has been received, to actually allow the end user to accept the data once they've reviewed it with the patient. The United States Core for Data Interoperability, or USCDI, is a standardized set of health data classes and constituent data elements for nationwide interoperable health information exchange. A USCDI data class, what you see bolded in this slide, is an aggregation of data elements by a common theme or use case. A USCDI data element, what you see as bullets under those bolded classes, is a piece of data defined in USCDI for access, exchange, or use of electronic health information. The USCDI is a continually evolving data process, and before anything is defined, once a draft is settled, public comment is received regarding that draft. Currently, USCDI draft version 7 is in the process of receiving this public comment, whereas certified electronic health record vendors are required as of January 1st, 2026, to have USCDI version 3 or higher enabled in their system. Version 3 is pictured in this slide and the next slide. And what this means is that the system's end users must be able to both document and receive all of the data in version 3. Coded data exchange is useful for all healthcare constituents, not only for patient care, but for prior authorization, quality measurements, benefit determination, and payment purposes. This is the rest of US CDI v3 that's now in all certified EHRs. The evolution is, as I already described, means that in the next version is evolving. Version 3 is plus the new classes and data elements in version 4, what you see on this slide. Version 5 is version 3 plus 4 and the new classes and data elements in version 5. Version 6 is version 3 plus version 4 plus version 5 and the new classes and data elements in version 6. And you can assume version 7 is version 3, 4, 5, 6, plus anything new in version 7. These are the new classes and data elements proposed in draft for version 7. This is the next slide for that version 7, and the final slide for version 7. So as you can see, draft version 7 is a whopper. I now have a polling question for the audience. Are frameworks and networks responsible for ensuring that certified electronic health record systems and health IT vendors comply with the US CDI currently mandated version? I'm curious about this question because I didn't really go over it. So I'm curious to see what people think. And it looks like we have a slightly, well, no, it's moving around, but we have about a 50-50 split. But actually, the answer is no. Under the Health and Human Services, the Office of the National Coordinator for Health Information Technology, or ONC, is responsible for certifying electronic health records. For providers to participate in the Medicare Promoting Interoperability program, they must use certified electronic health records. There are a lot of P's in that, so I challenge anyone to say that 5 times fast. Query interoperability includes all of the exchange purposes defined by the Trusted Exchange Framework and Common Agreement, which I'll be speaking about shortly. However, specific examples that are clinical include if I'm seeing a patient in the emergency department and I have no information about that patient, I can query all of the systems where that patient might have been seen and get data back to treat the patient. Also, if I have a full clinic schedule the following day, my system can query for all of my scheduled patients, the established patients as well as the new ones, to get all information that might have happened between the last time I saw the patient and when they're due for this appointment. So it can be exceedingly useful, the query. A query for patient records goes from point to potentially many points, as documents will be returned from whatever facilities hold information on the patient. Some QHINs, for example, the MedAllies QHIN, have a record locator which finds patients across all QHINs and their edge system and returns all of the patient data. This QHIN then cleans the data, for example, deduplication of patients' data. Facilities holding the information return the patient data to the requester across the TEFCA network of networks, returning all available, reliable, and usable information. This is useful for many healthcare constituents and may dramatically improve the data quality and enhance efficiency of obtaining the data, such as for benefits determination and payer-required data. The Trusted Exchange Framework and Common Agreement, known as TEFCA, is the U.S. nationwide network of networks for health information exchange. TEFCA was created by the HHS Office of ONC to remove barriers for sharing health records electronically among healthcare providers, patients, public health agencies, and payers. TEFCA provides one set of network participation policies, one set of nationwide connectivity services, and one approach to network oversight for all participants. Having gone live at the end of 2023, TEFCA's governance has matured into a participatory public-private collaborative model. Additionally, for a health information network to become a qualified health information network, or QHIN, under TEFCA, it must demonstrate it's up to the task of facilitating cross-network exchange at nationwide scale. The requirements are rigorous and specific. All networks are tested across each other before a new network can be approved. Not only do such networks need to address aspects like cybersecurity insurance, annual third-party security assessments, and U.S. ownership status, they also need to demonstrate their technical competencies as part of regimented onboarding process. Moreover, QHINs are also required to ensure participants and sub-participants that are attached to their network adhere to specific terms of participation. I promised you I would discuss the TEFCA exchange purposes, and we'll go over these now. Treatment is the sharing of health information to support clinical care, including for treatment, diagnosis, and management of a patient's condition. Payment is exchanging information to support billing, reimbursement, and payment processing between providers, payers, and other stakeholders. Healthcare operations is sharing data to improve the efficiency and effectiveness of healthcare delivery, such as scheduling, resource allocation, and quality improvement. Public health is providing information to public health agencies for surveillance, reporting, outbreak investigation, and other public health activities. Government's benefit determination is sharing health information to support eligibility and benefit decisions for programs such as Social Security, Medicare, or Medicaid. Individual access services is allowing patients to access and aggregate their own health information from TEFCA connected sources. Now we're moving on to push messaging, for which the framework is direct trust. Some examples of push messaging are clinical messaging, payment functions, for example, prior authorization messaging, healthcare operations, for example, messages regarding gaps in care, care management and transitions, and public health and government benefits determination, both of which we've previously discussed. With direct push interoperability, endpoints may be as granular as an individual clinician to a clinical department within a healthcare system, or as broad as a specific healthcare constituent organization. Direct exchange is point-to-point across a direct health information service provider, or HISP, network or networks. As already mentioned, the direct framework is direct trust. In this example, a specialist has consulted on a patient and is pushing the consult information back to the patient's primary care physician. Since both the PCP and the specialist use the same HISP, which is the network, the data only crosses this network. If they use different HISPs, the data would be pushed from one edge system across their HISP to the second HISP and into this HISP's edge system. Let's talk about the state of referral. And I was very interested to see that 50% of you felt that it did take over an hour, and well over half, at least 3/4 or more, said that often they never know what happens with the referral process. 360X, so in order to manage referrals, 360X protocol was created. Referral management is difficult to track and follow, often meaning that the patient doesn't receive required care, the specialist has insufficient information to treat the patient, often unnecessarily causing duplicate testing, which is expensive and painful, or at least inconvenient for the patient. Finally, the requesting physician doesn't receive the specialist's information or receives it as a fax, adding documentation burden and the risk for transcription errors, potentially causing adverse events. The 360X closed loop referral is a collaborative effort sponsored by ONC, included HIT vendors, health information service providers, clinicians, and other industry partners. 360X is a closed loop referral protocol approved by the IHE that tracks a referral until the loop is closed and the referring provider receives the consult information. It's important to note that because it's an IHE approved protocol, all EHR vendors implementing or anyone implementing the 360X protocol must use the same implementation guide and adhere to the standards. It was developed to work with standards and specifications commonly used within health IT systems, thereby having a low bar of entry for these systems. CCDA is used for clinical content, direct protocols for transport, XDM for establishing context, and HL7 v2 messages for referral workflow. The HL7 v2 messages lead to being able to track the transparency of progress until the loop is closed. If a patient no-shows having an appointment at the specialist's office and doesn't show up, an automatic message is sent from the specialist's office back to the PCP. The same is true if the patient cancels. This gives the PCP office the opportunity to follow up with the patient and ensure that the patient gets the required care. The first successful implementation of 360X in 2024 involved the Centauri HISP, Epic, and NetSmart. I'm using this graphic to demonstrate the 360X referral protocol. The 360X referral request containing the patient's relevant information is pushed from the PCP's EHR across the Centauri HISP used by both PCP and specialist in this instance into the specialist EHR. The office staff check the specialist's schedule, and as the request can be accommodated, they push back and accept notification, and an appointment is scheduled. If the specialist was unable to accommodate the patient, they would rather instead send a decline notification, and the referring organization would seek another specialist, ensuring the patient received the required care. When we were establishing the protocol, we talked at length about this decline notification. There were just a couple of clinicians that were involved in these meetings, and mostly they were technologists from the different EHR vendors and others. The technologists wanted to use reject as the response, and I explained to them, along with the other clinician, that if a specialist organization rejected my patient, I would be unlikely to refer that patient to them again. Therefore, we chose the word decline. The referral loop is closed only when the specialist returns the consult information to the referring provider. In many EHR systems, this is automatic after the specialist has completed that consult note in their own EHR. A group of vendors and others meet bi-weekly, and as you can see, these are the involved organizations that meet in that week. In the work group, we discuss implementations, workflows, any issues that are technical that people are having, and it really facilitates adoption of this nationally in a more rapid fashion. The blue title of this slide is the URL for the ONC 360X project. The IHE approved protocol is the 360X closed loop referral, but we've also defined 360XL, which is long-term acute to long-term post-acute care transfers. We've defined long-term post-acute care transfers to ED, as well as 360X SDOH closed loop referrals. I wanted to give you a little bit of information before we turn it back over to Dawn, because here you can see examples of what are called community-based organizations, also known as CBOs. It is important to mention that CBOs are not HIPAA-covered entities. Referral data, therefore, should be limited to the reason for referral. In other words, the SDOH diagnosis code, for example, homelessness, that has been used when documented by the clinician, as well as that the patient should consent for these referrals to be made. This is what a 360X SDOH referral would look like to a CBO. However, the CBOs are not likely to have an EHR, or if they do, it is likely that this EHR has minimal capabilities and therefore would be unable to utilize the 360X protocol. At least this is the case in the present day. However, SDOH hubs are designed to assist with ensuring patients get their SDOH needs met. They are also not HIPAA-covered entities, so limiting data and consent would still apply. Some hubs are interested in or already have implemented 360X. Now I'm going to turn the presentation back over to my wonderful, brilliant colleague, Dawn. Please take it over for the rest of this presentation.
Thank you, Dr. Miller. Now, one of the biggest challenges with addressing social needs is closing the loop. We can make a referral, but too often, as we saw in our polling question, we never learn whether the person actually received the service. That's why the interoperability work Dr. Miller just walked through matters. It helps us see utilization, confirm follow-through, and measure what's working in value-based care programs. So investments in the right people, processes, and technology are supported by very real results. Now, I know this slide looks like a dizzying collage, but I included these headlines on purpose to make 2 points. First, there's broad momentum across healthcare to partner with community organizations because these factors are major cost and outcome drivers. Second, even when it feels like attention has shifted elsewhere in healthcare away from health equity, the work is very much still happening. Now, many of you may recognize some of the organizations here, and I dare say many of you belong to these, and you likely don't need a definition of health equity or social determinants. But what's less visible but critical is the data and workflow challenges, accessing this information, sharing it appropriately, and getting confirmation back so we can tell whether these partnerships are truly delivering impact. And that brings us to another polling question. Which statement best reflects where your organization is today on social determinants of health and health equity? And A, which I hope is everybody's answer, strong strategy with consistent workflows. And I'm glad to see that some are falling into that category. B, pilots in progress. Also good. You got to prove out what you're doing. C, mostly ad hoc or program by program, which is an excellent start. Or early stage or not started. And we do have a couple of those, but it looks like most of the answers, strong strategy and consistent workflows, which is great. Excellent. So we will move along to our next polling question, which is piggybacks off the first one. What's the biggest reason social determinants of health initiatives stall or are not as effective as they could be in your organization? First speaks to what Dr. Miller just took us through. No closed loop feedback. You can't even confirm what services were received. Then we have limited community capacity. There just aren't enough community partners, which could be the case, particularly in rural areas. Also, data, consent, sharing barriers, some of the technical things that we need to think about. Or hard to prove the ROI or outcomes to get those people, processes, and technology. And it looks like we've got a smorgasbord of answers. We've got about 30% no closed loop feedback, got about 30% limited community capacity, 30% hard to prove the ROI. And I actually have something to say about that in a later slide. And then a lesser percentage of data, consent, and sharing barriers. All right. Thank you for participating in our polls. So, as I begin to introduce our main content today, I realize we may have some people who've had less exposure to these terms or are newer to the industry. So, I wanted to review the variety of terms associated with health equity. And they don't mean the same thing, even though you often see them used interchangeably. Now, health equity is where we'll start. And it's a state in which every person has the opportunity to achieve their full health potential and which no person is disadvantaged because of social circumstances. Then we move to health disparities. These are preventable differences in disease burden or opportunities to achieve optimal health experienced by socially disadvantaged individuals and communities. Then we have social determinants of health. These are conditions in which people are born, grow, work, live, and age. These are a wide set of forces and systems that shape life, such as economic, political, and social policies, and other systems. Then we move to social risks. These are adverse social conditions associated with poor health, such as poverty or social isolation. And then to complete the loop, we have social needs. These are an individual's immediate necessities determined by that person's preferences and priorities. And I like to say to understand how they're interrelated, follow this graphic counterclockwise starting at health equity to understand how they are interrelated. Meaning, we address health equity by addressing health disparities, by addressing SDOH, by addressing social risks, by addressing social needs. So once we're using the same terminology, the urgency becomes clearer because these factors aren't peripheral. They account for a large share of what drives health outcomes. Let's take a look at what these are and the evidence behind their impact on the next slide. Now, the focus of our presentation today will be on SDOH, and these have been estimated to be responsible for 80 to 90% of health outcomes and are not usually addressed as part of a standard biomedical health assessment. As a result, traditional medical care only addresses about 10% of the avoidable and controllable factors that make a population healthy. Not only that, but according to a recent report, 68% of patients have an SDOH, and 60% of these say they have never discussed them with a provider. That gap between how much SDOH drives outcomes and how rarely it's addressed has real consequences. And here are a few data points that show what happens when these needs go unmet. First, unmet social needs means more acute care. Insured adults reporting financial, housing, or food insecurity has significantly higher ED use than those without social risk. Second, those accumulating needs raise the risk. In a recent study of a federally qualified health center cohort, having 2 to 3 or more unmet needs increased the probability of both ED visits and hospitalization over 12 months. And then also, homelessness particularly magnifies utilization. People experiencing homelessness had around 310 ED visits per 100 persons per year in a 2020 study versus around 40 for those who are not homeless. Now, as I mentioned earlier, it's highly likely that most people in this audience have at least heard of SDOH. And depending upon who you ask, there could be anywhere from 5 to 12 SDOH. Now that we've grounded what SDOH are and why they drive outcomes, we're going to shift to a practical question: how we identify them and turn them into usable data. And we're going to start on this slide that you see on the screen right now for sounding a jumping off point. And this actually comes from CMS. And this graphic, of course, has a lot going on, but I want you to focus on the workflow it reinforces. Screening, and that's all the way to the left. In the middle is documentation, and then coding is all the way to the right. And these are the 3 steps that turn social needs from good to know into something we can act on and measure. Now, first, screening, all the way to the left, is the intake, using structured tools and templates that fit existing clinical workflows. This can also be done manually and on paper, but more and more these days it is being done actually as part of the EHR workflow with existing templates. Then we have capture and documentation, and that's making sure that the need is clearly described and tied to the patient's situation. Then we have coding all the way over to the right. And this is where that documentation becomes standardized ICD-10 diagnosis data. This is often done using Z codes and the Z55 to Z65 range. And these codes come with very specific rules about who can capture them and how it needs to be supported in the note. And those are in the ICD-10 coding guidelines. So that's where you go if you want to check out the special rules that apply to these. And then there's a step that's not shown here. That is the claim. Even when you do everything right here, the claim format may limit how many diagnosis codes can be transmitted. And this is the electronic data interchange format, the 837, which means some SDOH codes may not travel on the claim. And this is a known limitation that's being hopefully addressed in future versions of the 837. That's why the best practice is capture it, code it, and retain it, even if it doesn't get billed, because it still drives care planning, reporting, and downstream referral coordination. So next we have an interactive activity, and I call this myth or fact, because now that we've talked about how social needs are identified and captured in our systems, let's pause for a moment and reflect on some of the assumptions we all carry about these needs and their impact. So our first one is myth or fact. A patient's diet is solely a matter of personal choice. And luckily, we've got our responses rolling in. And luckily, most of you have correctly identified this as a myth. Access to healthy food is often an SDOH issue. Lack of access to affordable, nutritious food, meaning being in a food desert, knowledge about healthy eating, and cultural dietary practices are significant SDOH that influence diet. Our next is myth or fact. An individual's neighborhood has significant impact on their health outcomes. All right, our responses are rolling in. And I'm glad to say that it looks like we have everybody correctly identified this as a fact. Neighborhood and built environment is an SDOH. Neighborhoods with poor air quality, lack of green spaces, unsafe environments, limited healthy food options, and high crime rates significantly impact health. Our next is myth or fact. If a patient has insurance, all of their healthcare access barriers are removed. All right. And so we've got responses rolling in. And luckily, all of you correctly identified this as a myth. Things like transportation, childcare, language, many other things can still be barriers regardless of someone's insurance status. Next, myth or fact. Homelessness is primarily a mental health issue. See, we've got our responses rolling in there. We've got some fact. Most folks correctly identified this as a myth. While mental health issues can contribute, homelessness is a complex SDOH, often driven by economic instability, lack of affordable housing, and systemic issues. It also exacerbates mental and physical health problems. The next is myth or fact. Focusing on a patient's social needs is outside the scope of revenue cycle professionals' jobs, or anybody's jobs in healthcare for that matter. And it looks like our responses are correctly identifying it as a myth. It's increasingly recognized as crucial for holistic care. Myth or fact? Telling individuals to have healthier habits will not motivate them to improve their health. What do you all think about this one? A little more split. This is a fact. This vastly oversimplifies the complex interplay of SDOH. Telling someone to eat healthy when they live in a food desert or exercise more when they have an unsafe environment ignores fundamental barriers for equitable access to care. And last but not least, myth or fact. It is the government's responsibility to address health-related social needs and determinants. All right, and our responses for this one are a little more split. This is kind of a trick question. And this is a myth. Various entities have a role, not just the government. Communities, payers, providers, and individuals all have a role. Thanks for engaging with that, because those statements highlight how easy it is to underestimate the role social factors play in health. Now, let's put some numbers to this and look at what two common social drivers, loneliness and food insecurity, cost our healthcare system and why they show up in utilization. So I wanted to ground SDOH in something every payer, provider, and care manager understands, and that's cost and utilization. Loneliness is a great example because it's common and it drives real clinical risk. What you're seeing in red on this slide is the price tag associated with the downstream conditions loneliness is linked to: depression, dementia, heart disease, and stroke, plus lost productivity. Now, the point isn't to memorize these numbers. Take a look at what's showing up now on the bottom right of your screen. Big numbers. It's to recognize that when social needs aren't addressed, the system pays, often later and often in higher acuity settings. Now, on the next slide, for those of you working in value-based care, this seems to be a straightforward equation. Food insecurity increases chronic disease risk and complications, and that equals avoidable spend. The prevalence of these is high, the cost is high, and the downstream conditions are exactly what value-based care programs are measured on: diabetes control, cardiovascular events, preventable ED use, and hospitalizations. This is one reason SDOH data belongs in a core strategy and not just as a side IT project. Now, since this audience is likely composed of many who work in risk adjustment and quality for payers or payviders or ACOs, similar organizations, I thought it would be helpful to tie the food insecurity determinant to the HCCs in both the Medicare Advantage and commercial risk models to demonstrate the impact from a different perspective. Now, even though the determinants themselves do not risk adjust, they most certainly contribute to the chronic conditions listed here. And given their role as major cost drivers, it stands to reason that collecting complete and accurate data about them should be a priority. We will discuss that in upcoming slides. Now, as we discuss the money, it's worth noting that recent scholarship has made progress in calculating the ROI for SDOH interventions, something that has historically been difficult. I'm happy to share those links if you want to follow up with me after the webinar. That said, addressing these determinants goes beyond ROI and big numbers. Now, zooming back out, the core challenge with SDOH is churn. And in the US, without universal health care, care is fragmented across many payers over someone's lifetime. I once counted 13 different health plans I've had since childhood. Many I barely remember. Now, that lack of a longitudinal, centralized view means a payer that invests in something like housing stability may never see the return if a member moves to another payer. Now, this churn-driven underinvestment shortens time horizons and discourages investment in prevention, chronic care, and SDOH. Policy responses to this, because remember, I'm the policy person, generally fall into a few buckets: lengthening payer relationships, standardizing or mandating investments, sharing savings across payers and sectors, or shifting payment models towards longer-term value. However, the bottom line is this: someone has to pay for prevention and someone has to pay for outcomes. And if we want to address SDOH fairly and effectively, the focus has to shift more towards prevention and not just the outcomes. So now we'll move into another polling question. Do you currently link SDOH insights to chronic condition programs such as diabetes, congestive heart failure, any of the others? And luckily, we're seeing a lot of yes routinely. We have sometimes, not yet, or not sure. So it's good to see that this is being tied to these chronic condition programs that you saw on our slides are very costly in terms of outcomes. Excellent. Thank you. All right. So this is my favorite part of the presentation, and I hope it will be yours too. Now, up to this point, we've talked about SDOH in the abstract. This note makes it painfully real. This is a patient living unsheltered and experiencing food insecurity, and those aren't just side notes. They directly shape whether chronic illness and wounds can be managed at all. When you're unsheltered, such as this patient, the basics of a treatment plan fall apart. It's hard to keep appointments, get labs done, store medications properly.
Apologies to the audience. I think that Dawn's internet has dropped, so I'm actually going to currently take over. This is Dr. Miller. So we're moving now. I'm not sure where she dropped, but we're moving to this slide. We just reviewed the patient's note, and we know that this slide shows what happens when a patient like the one we've just discussed does not receive SDOH support. The only way to change this trajectory is to close the loop so referrals aren't just sent, but confirmed, and so information can move reliably between care teams and community resources to support follow-through. On the left, you see the patient living unsheltered and trying to survive day to day, including getting food from unsafe environments. Here is fishing in a polluted river. Chronic wounds are exposed to contamination, resulting in the patient having an infected diabetic foot ulcer. You can see that, that's the red. Without support in place, the system first encounters this patient in crisis through the emergency room. The wound is beyond conservative treatment, and he undergoes a foot amputation. As the underlying conditions haven't changed, once the patient is discharged, he's back into the same environment, fishing for food in the same polluted water. His wound, fresh from surgery, not surprisingly, is reinfected. He then returns to the emergency department, and this time the wound requires an above-the-knee amputation. This is reactive care. It's costly, it's traumatic for the patient, and it's exactly what happens when social needs are identified but not addressed in a way that changes the patient's reality. In value-based care terms, closing In value-based care terms, closing the loop and making the exchange interoperable is how we move from a tragic utilization pattern to measurable outcomes and preventable cost reduction. Let's see on the next slide where we change the trajectory and what that looks like. Here we have the same patient. In the last slide, we saw the no support trajectory with repeat emergency visits, escalating procedures, and ultimately amputations because the underlying conditions that make healing possible never changed. This slide shows the alternative path when SDOH support is built into the workflow. The patient still up in the emergency department with a diabetic. Critical steps early: screening and referral. In the ED or clinic, the team can pull in the information they need to understand the full picture, recent encounters, current problems, and what services may already be involved. So we're not starting from scratch every time. Then we shift to push. Instead of the hospital social worker handing the patient a list of community resources at discharge and hoping for the best, we send a structured referral out to a community coordination hub that connects the patient to concrete supports, housing, food resources, transportation, whatever is driving the instability you see on the left side of the slide. And the most important difference is what happens next. The hub and community partners can send information back, accepted, scheduled, delivered. So we're not guessing at whether the patient received the services that closed the loop. The care team follow up intentionally, adjust the care plan, and monitor outcomes like labs, medication access, and whether ED or other avoidable utilization starts to drop. Now, with transportation, the patient sees a PCP. His foot ulcer is treated and, as you can see, ultimately heals. So the contrast here is simple. Without support, care stays reactive and the cycle repeats. With support plus push-pull interoperability, we can coordinate services, confirm follow-through, and change the patient's clinical trajectory before the next crisis. Now, after everything you've heard today, the complexity, the scale, and the persistence of health equity issues and social determinants of health, it's completely natural to feel a bit overwhelmed. You might be thinking, these problems are enormous, and I'm just one person, or we're just one organization, one payer. How much difference can we really make? I want to leave you with a different perspective, captured in a short story called The Star Thrower, illustrated here. A child is walking along a beach, throwing a stranded starfish back into the ocean one by one. An adult points out that there are miles of beach and hundreds of starfish. Surely throwing a few back can't possibly matter. The child picks up another starfish, tosses it into the water, and says, "It mattered to that one." Interoperability work, SDOH intervention, and health equity initiatives often feel like those starfish, numerous, urgent, and scattered. No single data connection, referral, or insight solves the whole problem, but every connection that closes a gap, every shared data set that reveals an unmet need, and every intervention that stabilizes housing, food, transportation, or access changes the trajectory for real people. For one member, it means fewer missed appointments. For one family, it means earlier interventions instead of crisis care. For one community, it means a system that finally sees them more clearly. So while none of us can save every starfish, interoperability gives us better vision, better coordination, and better odds. When we use data intentionally and responsibly, we don't just move metrics, we move lives, and that's absolutely what matters. We want to thank you so much for attending this session, and we greatly appreciate your attention. We'd now like to open it up for questions, which Gretchen will be managing. Over to you, Gretchen.
The only question we have is whether the training recording will be shared. And yes, Rise usually posts that, but we will also post it on our YouTube channel once we receive the recording from Rise.
And we'd like to very much apologize for our internet issues. My colleague Dawn lost all internet in her whole area. Thank you so much for your patience and staying with us until the end of the session. Thank you very much. And unless there are other questions, and I do believe someone raised their hand, so if you're still on and you still had a question, we can unmute you and address that. Okay, seeing no hands raised, I think we will end it here. Bailey, did you want to wind it up, please?
Yeah, thank you so much. And thank you again to everyone for attending, and especially a big thank you to the Centauri Health Solutions team for putting on a great webinar today. As they mentioned, and just a friendly reminder, you will be receiving a copy of today's slides as well as a copy of the recording from Rise tomorrow. So be on the lookout for that as well. And if there were any questions that the team was unable to get to, please feel free to reach out to them, or they will follow up with you directly after the webinar. But with that, it concludes today's session, and we look forward to seeing you all next time. Have a good one.